I'm Dr. Yogesh Mang, and this is a very short and crisp presentation on pancreatic cystic neoplasms. So, the various types of neoplasms which we see in pancreas are IPMN, serous cystic neoplasm, mucinous cystic neoplasm, or SPEN. And when we look into the data, IPMN is something which is the most common cystic neoplasm of pancreas. The most common pancreatic cyst could be a pseudocyst, but if you look at the cystic neoplasm, intraductal papillary mucinous neoplasm is the commonest cystic neoplasm of pancreas. So what are the types of cystic lesions which we see in pancreas? The first one is pseudocyst. It's more frequent in men as compared to women. It can be seen in acute or chronic pancreatitis. Imaging wise, you can see mainly pseudocyst in body or tail. These are usually unilocular, thick walled, and they have a pancreatic ductal communication in most of the pseudocyst. They may contain fluid or sometimes they may also have debris. The aspirate in pseudocyst is usually dark brown colored and the fluid is high in amylase and lipase, and the CEA content in the fluid is very low. The malignant potential of pancreatic pseudocyst is nil, zero. There is no malignant potential in pancreatic pseudocyst, as we all know, right? Next, serous cystadenoma. So 75% of serous cystadenomas are seen in women, and these are seen in 6th to 7th decade of life. These are seen in older women. Okay. Majority of serous cystadenomas are asymptomatic. If there are multiple serous cystadenomas, they might be associated with von Hippel-Lindau syndrome. Now, imaging feature. They could be seen in anywhere, sometimes in body, tail, or even in head. They are usually microcystic or honeycombing like pattern is seen, or there is a central scar which is seen, which looks like a sunburst pattern or central calcification, which is classical of serous cystic neoplasm, but it is present only in 30% of serous cystic adenomas. There is no pancreatic ductal communication in serous cystic neoplasm. Now, if there is no pancreatic ductal communication, naturally there will not be any amylase or lipase in the fluid, and even there is no mucin, so CEA level of the fluid will be low. So serous cystic neoplasm aspirates have low CEA, low amylase, and low lipase. The fluid is usually straw colored, and the malignant potential in serous cystadenoma is less than 1%. These are practically non-malignant cystic neoplasms of pancreas. Coming to intraductal papillary mucinous neoplasm. These are seen commonly in both men and women and are again seen in older age group. Now IPMN, we have three types: side branch, main duct, or mixed one. The side branch IPMN is actually the most common incidental pancreatic cystic neoplasm, or most common incidental pancreatic cyst is the side branch IPMN. Now these side branch IPMN could be multifocal and they have communication with main pancreatic duct. So this is a side branch IPMN. As you can see, they have communication and sometimes the main duct might be dilated. Okay, they have a very low risk of cancer progression. The main duct IPMN is much less common than the side branch IPMN. They have usually a dilated main pancreatic duct. The main pancreatic duct could be a segmental dilatation or a diffuse dilatation all over. Main duct IPMN have a very high malignant potential of around 40 to 60%. If the main pancreatic duct diameter is more than 10 mm, then the chances of malignancy are more high. And mixed, these are rare and they have the same risk as a main duct IPMN. So as you can see here, this is the main duct IPMN, in which you have a complete fusiform, a complete dilatation of the main pancreatic duct. And one more important feature of main pancreatic duct is this, the fish mouth appearing ampulla, where you can see a mucin which is coming out. Now, as we know, it's an intraductal papillary mucinous neoplasm. Mucin means the fluid CEA will be high and it's a ductal communicating tumor, so it's naturally going to have a high amylase. So a ductal communication gives high amylase and mucin gives high CEA in these fluids. Coming to next, that is mucinous cystic neoplasm. These are almost exclusively seen in women. These are seen in 5th to 6th decade. They are vast majority found in body and tail. These could be unilocular or have septations or have a wall calcification, which is also known as eggshell calcification. As you can see, there is a calcification in the wall here, that is eggshell calcification, and they do not have main duct communication. Mucinous cystic neoplasm do not have main duct communication. As there is no main duct communication, so MCN will not have amylase which is raised. But as it's a mucin tumor, they will have a high CEA. And mucinous cystic neoplasm have a high malignant potential of around 10 to 20%. So if you have a mucinous cystic neoplasm, it becomes an indication for surgery. As I said, it could be a unilocular or they may have septation. So here you are seeing some septas in the cystic neoplasm there. Lastly, SPEN, that is solid pseudopapillary epithelial neoplasm. 10:1 ratio of women is to men. Invariably, practically most of the SPEN or nearly all the SPEN are seen in women, and these are the tumors of younger age group, that is in the 20s or 30s. Most common presentation could be abdominal pain. Now they may occur as a cyst or they may have a solid component. They may also have some cystic necrosis as the tumor enlarges in the size. So here you can see a solid cystic component with some enhancement in the wall. That is the characteristic of solid cystic neoplasm or a solid pseudopapillary epithelial neoplasm. They also have got a malignant potential of up to 10%. So a SPEN tumor is an indication for surgical resection. Cystic neuroendocrine tumor or cystic pancreatic neuroendocrine tumor, these are usually non-functioning. They can be seen as a hypervascular lesions with cystic components, and the neuroendocrine tumor cytology is positive. The aspirate are usually low in CEA, low amylase, low lipase, as there is no mucin or there is no ductal communication. So we just saw solid pseudopapillary epithelial neoplasm. It's seen in young female, so it's seen in daughter. Mother will have a mucinous cystic neoplasm. It is seen in age group of 45 to 55 or 60s. And grandma will have a serous cystic neoplasm, or grandmas usually have serous cystic neoplasm which are more than 70 years of age group. Just a look at this photo will give you a exact picture. So a pseudocyst may be a fluid collection or with some solid debris. Most of the times they have communication with the pancreatic duct. So they have high amylase and lipase, but the CEA level is normal. Then IPMN, it could be a main duct IPMN or a side branch IPMN. It's an intraductal papillary mucinous neoplasm, ductal. So the fluid will be high in amylase and lipase, and the mucin is there, so CEA will be high in IPMN. So IPMN will have both amylase high as well as CEA which is high. Then mucinous cystic neoplasm, there is no pancreatic ductal communication, so these will have only CEA which is raised. The amylase will be normal, and serous cystic neoplasm will not have any of the component raised. Okay. Just a revision of all the fluids. As I said, pseudocyst will have high amylase, CEA will be low, there won't be any mucin, cytology will just show inflammatory cell. Serous cystic neoplasm, amylase, CEA and all the markers are negative. They might get a mucin stain and they have a glycogen rich cells on cytology. Mucinous cystic neoplasm, no ductal communication, so amylase is low, CEA is grossly raised, and they have mucinous cells on cytology. IPMN, papillary mucinous neoplasm intraductal, so amylase is raised, CEA is raised, its viscosity is high, and they may also have mucinous cells. And so SPEN tumor, that is SPT, no raised amylase, no raised CEA, they have a polygonal epithelial cells, a classic feature of SPEN tumor.